Good afternoon. Welcome, everybody. This is the Recovery Science Echo Series. Thank you for being here today. My name is Andrea, and I will be helping to facilitate this conversation today. Before we start, I want to remind you that this session is being recorded for later distribution. However, the information that you see on the chat will not appear on the recordings. So we invite you to keep adding your names, email addresses, and affiliations on the chat. We will use this information to confirm your attendance to this class. But if you're joining via phone, you still can send us an email at bewelltexas@utesca.edu so we can associate your phone numbers with your names. And today we're very excited to introduce our two guest speakers, Kris Kelly and Michelle Lennon. Thank you both of you for supporting our recovery science program. We're going to start with a 25 minutes didactic presentation by Kris, followed by your questions and comments. Then after that, we'll move to some brief announcements. And during the second part of the session, Michelle will be sharing with us her experience with this incredible organization. And after that, of course, we will open again the floor for all of you to take part of the conversation. Please remember that the Echo series is a space for you, the learners, so we want to hear your perspectives and your opinions. So your voices are welcome in this space. So with that, we're going to start with some introductions from the Recovery Science Hub, and I'm going to start with Patrick. How are you today?
I'm doing great. Thank you. Patrick Hibbard. I am an assistant research scientist, Chestnut Health Systems, the Lighthouse Institute, long name. But I'm a formerly incarcerated scholar in long-term recovery myself. And so I love this work. I love this echo. I'm so happy to be here with you guys.
Thank you. We're excited to have you here as well. Cheryl, on the road and on the go, but she's here. You want to introduce yourself?
Thanks, Andrea. I'm Cheryl Pacapelli. I am a person in long-term recovery for 35 years and blessed to be the project director in New Hampshire for the statewide network of recovery community centers. And I'm so glad to be here, but I'm going to keep my camera off to stay safe. So looking forward to hearing this echo, though. Thanks.
Thank you, Cheryl. Please drive safe.
I got it.
Kristen. Kristen, do you want to introduce yourself?
Yeah, hi, I'm Kirsten. I'm the project coordinator for PRIN, and I'm really happy to be here.
Thank you. And with that, I think that we can start with our didactic presenter of the day with Kris Kelly. Again, welcome to the session. Are we ready to start sharing your didactics? We can start. Thank you.
Am I sharing right out of the gate? Yes, okay.
Yes, you may. Why not?
Thank you.
But
Yeah,
in the
you're in the hot
meantime, you
seat.
can introduce
I'm in the
yourself.
hot seat. Thank you. Can everybody see
Exactly.
that okay?
Yes, we see
All
it.
right. All right. So, just a big thank you for inviting me to be with you today and to talk about recovery community organizations. I'm super passionate about recovery community organizations. I'm a person with lived experience overcoming substance use challenges myself. I used to run a recovery community organization in Minnesota prior to the work I'm doing currently. So currently I work for the University of Wisconsin-Madison as a project manager on a couple different grants. One of those is the Great Lakes Addiction Technology Transfer Center, and the other is the Center for Addiction Recovery Supports. So both of those are SAMHSA-funded training and technical assistance centers where you can go for support to receive what we call technical assistance, which is essentially expertise, consultants, trainings, all that good stuff at no cost because SAMHSA funds our work. So I'm going to jump into a little bit about the how and why of recovery community organizations. Forgive me if it's things that you already know about. Do you want me to read through these disclosures, or have the audience can read
You
them?
don't have to. It's okay. You
Okay.
can continue. Thank you.
Okay. So some learning objectives for today. Really, I'm here to help you remind you of or inform you of, if you don't know, some of the core functions of recovery community organizations, how and why they were formed, a little bit on the history, some current gaps we see in the current recovery science literature, and then some ideas about like how do we keep moving this work forward. So when we think about the evolution and the growth of recovery community organizations, the kind of first formalized recognition of an organization existing called a recovery community organization is in the 1990s. We know that organizations existed prior to that really served the role of being a RCO. So from here on out in the presentation, I'll refer to recovery community organizations as RCOs. So we know organizations existed before the 1990s, but in the 90s is when SAMHSA created the first recovery community support program grants. We sometimes refer to that as the RCSP grants. And I'll touch on that the name was actually changed to the Recovery Community Services Program grants later on. But initially it was Community Support Programs grants. The idea was that there was so much widespread stigma, which we still contend with, around people who had substance use challenges, that it created barriers to resources and different opportunities. As groups of people in recovery started to come together, they recognized the power of other civil rights movements. So if we look at the disability justice movement, AIDS, LGBTQ, Black and women's rights movements, they really recognize the power in that collective advocacy. And so as people got together, it was like, well, we need these similar efforts for people in recovery because although we had treatment, that acute care certainly didn't address that widespread stigma, often policies that didn't support people's long-term recovery. And again, kind of lack of those community-based resources, and that we needed representation on a national level. We knew that public perception informs public policy. So the way people think about something, our neighbors, our friends, our communities, our churches, our schools, all these different entities, the way they perceive people in recovery or people with substance use challenges really impacts our public policies. And so we knew we needed to address that, also provide education, broad education to our general population about what is addiction, what are substance use challenges, and that people can and do recover. So there was just this growing emphasis on this movement that we were forming. And so that RCSP grant from SAMHSA really funded those first recovery community organizations in the 90s. So since that time, what we've seen is kind of a few RCOs here and there, kind of first on the East Coast and then on the West Coast, and then they moved into the center, as most movements do, to now, I think at my last count, there were over 400 recognized recovery community organizations across the nation. Most states have recovery community organizations. Through the Center of Addiction and Recovery Support, we have a directory of RCOs where you can see state by state where are these recovery community organizations, as well as other peer-run organizations. Some are brick and mortar spaces. Now we have completely virtual recovery community organizations, which is really exciting, so that they're not confined to just serving people in a geographic space. Anyone across the nation, really worldwide, can access these organizations. And again, there's this strong focus on changing that public perception of addiction and recovery. I don't have my chat open, so if anything comes up, if a question comes up and it's pertinent, feel free to pause me and I'll respond. So some core elements of recovery community organizations, so that they're formed by typically groups of people coming together. You'll hear later on about Michelle's journey. So this is going to be a really good example of how RCOs are formed. So it's typically groups of people that have come together and they're saying, hey, we may have treatment, maybe you don't have treatment, but we may have treatment. We may have that acute, time-limited, kind of bound care, but what are we doing for people after that? How are we supporting people in rebuilding their lives? So I know from my own experience, that was a steep cliff to come off of. Leaving a formal treatment setting and kind of going back to real life. I myself, the first couple times I attended treatment, I wasn't familiar with what supports were out there. And so again, sometimes that ended up in a return to use for me, in which case then I would go back and go through treatment and have that steep cliff, and I needed those community-based supports. I wanted to be around like-minded people. So RCOs are independent grassroots nonprofits formed by people in the local recovery community. They come together, they form a nonprofit, they say, we want to address these issues. Often RCOs, their core activities are situated around three things. And so we see policy advocacy. So again, we want a seat at the table. We want to be engaged in our state's policy efforts. We want to ensure that things are aligned, that we're working towards these recovery-oriented systems of care. We want to, as RCOs, provide community education and outreach. And so not just education to the people like receiving services or the people accessing our services, but to the broader population. We want our communities to understand that most people actually do recover. Our media often kind of sensationalizes addiction. So what you see, public perception is, oh, these people, they're addicted to drugs and they do these bad things and they commit crimes and they never get well. Imagine if our newspapers were filled with the, over 23 million people who are in long-term recovery. If the front page told those stories, public perception would change, and they would say, actually, people do recover. My son, my daughter, my father, my neighbor, they actually can recover. And when we change the narrative, suddenly there isn't as much stigma, and then people feel better about saying, hey, I think I have an issue, and you don't often have to wait further down that continuum till things kind of, you've burned all bridges and you've, quote, hit rock bottom. People can reach out for resources and support and access the supports they need to thrive, to kind of change things and have a life in recovery. So that community education and outreach is really important. It's important that we're not stuck in brick and mortar buildings, that we're going out into communities and providing services. You've probably heard the term of serving people where they are. And so suddenly we're not just confined to hoping people walk through our doors. We're actually out in the community providing services and helping people understand that there's support available to them. And that we provide, RCOs provide a range of recovery support services that include peer-based recovery support, but peer-based is certainly not the only type of recovery support that RCOs provide. So they address things like accessing education, childcare, employment, reuniting with your family, with your friends, building up those social supports, social network that's not necessarily related to any formal like 12-step group or formal mutual aid support group, but just being friends with and hanging out with other people in recovery, to go to a book club, to go to the gym, to go to movies, to do all the regular life things. And so those are kind of those core activities of RCOs. RCOs serve not just people in long-term recovery, but their friends, their families, the professionals in our field, not just the recovery field, but all types of different professionals, social workers, clinicians, our judicial system. And it includes all pathways to recovery. So that's really important too. No one's required to follow a specific pathway in order to engage with a recovery community organization. You come in, myself, I didn't have a traditional pathway. I was able to kind of put together my own pathway to recovery, and that was supported through a recovery community organization. And so most RCOs kind of in their mission is mobilizing local resources to increase access to long-term recovery. And again, the person defines what that long-term recovery might look like, and certainly improving the quality of life for folks. The initial impact that we saw from these efforts in the 90s and early 2000s, we saw these connections being made at state and local and national levels. So we saw a movement form. We saw recovery get a seat at the table. We saw more funding created, often through SAMHSA, for recovery support services, for RCOs, for peer support services. We started to see that shift from acute, just solely acute care, so kind of that time-bound clinical care, to more that broader recovery-oriented system of care. And then also, again, a continuation of SAMHSA, the RCSP funding. And I just wanted to touch on too, like when I talk about those initial impacts I know in the state of Minnesota at one point, we had a policymaker, he presented a bill that said any Medicaid funded treatment, people had 3 attempts, and after their 3rd attempt at treatment, they were gonna cut off their Medicaid funding. And when the local recovery community got wind of this, we showed up for those hearings in mass. And so hundreds of people, meaning standing room only. And we testified, one person after another, that said, if I had only had 3 attempts, I might be dead. And actually the bill wasn't passed. And so to me, that's a huge part of what RCOs do, is they mobilize that local community to respond to things like that. Because without a local RCO, we might not have had that resource to put out the word, that call to action for all of us to show up and say, hey, no, we don't support this bill. So that's an example of work that an RCO might do. And I wanted to also touch on the work of John Kelly when he describes really kind of recovery capital and the idea of building recovery capital through a burning house model. And so he says, we've somewhat addressed the burning house, putting out the fire. So the idea that we have that acute care, we have withdrawal management, we have some systems in place that might put out the fire. And that our recovery community organizations and recovery community centers can start to do the work of fire prevention, so helping people avoid a return to use. We can provide some of the architectural planning. So how do we rebuild our lives? So do that recovery planning with folks. We can provide those building materials, so those recovery supports, those tangible things, the plan that somebody needs to walk through, and often provide those peer support services, so someone to walk through that path with them, and then often address those rebuilding permits. So a lot of times when we're in our addiction process, we might have interactions that give us kind of big barriers. We might lose our license, we might be incarcerated, we might come out of that our addiction careers with some things that have big barriers to accessing a life in recovery in the things we need. So certainly RCOs help people with those rebuilding permits. So I wanted to touch on, largely, as you've heard me speak, is community recovery capital. So a lot of folks are familiar with building recovery capital at the individual level, but where as a field we're kind of we're not seeing as much emphasis in research, especially, is around community level recovery capital. So you can obviously read the slide here, but community level recovery capital are the collective resources, the support, the systems within a community that help the individuals maintain long-term recovery. I often see this through the healing forest theory. So if you haven't heard that theory, it's kind of the idea that our system might pluck up this tree and that's in a kind of a dying forest and put it into this really healthy soil and water it and make sure it has sunshine and it's thriving and it's doing well. But then we pluck up that healthy tree and we put it back in this dying forest that the soil isn't nurtured and it's not getting enough sunshine and it's not getting enough water. And so we can't expect that tree to thrive in that dying forest. And so when we talk about community level recovery capital, that's kind of the analogy, is that we can pluck people up and make sure they're in these temporary environments where, of course, yes, they're going to thrive. They're getting the sunshine, the water, the nutrients that they need. But we also have to work on the forest, the place that they're returning to. And so we have to make sure that those supports are there. So part of that is addressing the stigma. Part of it is ensuring that friends, family, individuals are going to be supportive of a recovery pathway, that they have access to what anybody would want access to, education, to employment, to just deep connections with other people, to having a sense of purpose, to feeling like I can come and contribute to my community, and that I have meaningful representation in policymakers, and just all those things. So we want to ensure that we're also working on that community level recovery capital, as well as that individual level recovery capital. So one thing we've seen is that it's difficult to measure community level recovery capital. We know that. I've talked to Dr. David Best about this frequently, and I talked to Bettina Huppner as well. How do we start to address this? Because we can't just have funding that's solely focused on individual level, building individual level recovery capital. We need both. It's a both and situation. It's not one or the other. And so how do we start to measure community level recovery capital so that we can continue with those individual level recovery, that individual level recovery capital growth? So since 2013, excuse me, we have made really, really, really a lot of progress in the recovery movement. But again, we've kind of shifted focus from that community-wide support level to that individual support level. I know in my work, I often sit in rooms of researchers and they tell me about all the great work they're doing on the individual recovery capital level. And so I often try to turn the conversation back to that. How do we measure the impact an RCO has on the local community that it serves? What sort of things do we want to measure? What sort of things do we want to look for? Back then, if you don't know William White's work, he's a really profound recovery historian. back in the early 2000s, he warned us in his writings about risks of narrowing our focus to peer support services only. So again, we're a little worried that some of the broader RCO functions might be diminished, that our funding will start to focus on just peer support services and not on that community outreach, community education, policy advocacy. And those things are needed in order to continue with and growing our peer support workforce. We don't ever want our peer support workforce to become just a add-on to treatment. We want peer support to be a service of its own, that people can access it without going through treatment if they choose, that it's robust, that it's long-term, that we know that if we can help people and support them for 5 years, that the rate of return to use reduces greatly. So how can we build out those services, those long-term services, and have a focus on that community level recovery capital? Again, sorry. So some reasons for research on RCOs and that community level recovery capital. We want to start to find effective RCO models. So part of my work is building capacity in recovery community organizations. And we need to start to record what models are really working. We know like CCAR in Connecticut, that's a really effective model. They've been able to go statewide and support a large infrastructure. We're going to hear today from New Hampshire. Michelle and I, before we got on, were just talking about we need to record the history of what occurred in New Hampshire. How did we get to the point where they have this robust network of well-funded recovery community centers? Georgia has a really robust network of RCOs that are well supported, coordinated. They get technical assistance from their state. Again, we have to study and identify these models of what works, do the research, and produce an evidence base for it. We want to use that work to inform our policy decisions. So again, we can do all the work, do all the research, but we need to bring, I think RCOs can be the communicators and the mediators in bringing this information to our policymakers. So we don't want to lose that focus on advocacy and our place in policymaking, so that we're able to have a seat at the table about policy decisions and how our state funding is spent. In my last slide, I'm not sure on where I'm at with timing, but I'm just going to go to my last slide. And then we can go to questions and
Please
conversation.
continue, of course. Go ahead. Thank you.
So just again, words of William White. This marks. So sorry, you are all over my slides. This marks a shift from a near exclusive focus on intrapersonal process of addiction recovery to creating local recovery landscapes, a potent form of community recovery capital within which recovery can flourish. Using a clinical metaphor, the community is becoming the patient. And so that just really hit me in the idea of our individual efforts are important, but so is keeping our building healthy forests. So we want to make sure that the places that people are returning to are just as healthy as the individual, so that we can truly, genuinely support somebody's long-term recovery. And in my slides that you'll receive, I do have a ton of references to look at, but other than that, I can just take questions and I'll stop sharing.
Thank you, Kris. Thank you for that presentation. Yes, definitely that material will be sent to all our participants after the session. Let's open the floor for questions, comments, insights.
Hi, Andrea. This is Cheryl. I just want to say thank you to Kris. You did a great job in kind of talking about the history of it. And I remember the first RCSP grants, which we just got paid to talk to people. about recovery, right? And then like 4 years later, maybe it was 8 years later, they said, you need to do a service. They changed that S to service. And everybody was like, well, we talked. Like, what do you mean we have to do a service? And, that's when telephone recovery support and recovery coaching, like in a formal way, got started. So, I really appreciate you, like, kind of talking about that history of how we got here. And I remember back then people saying it's going to take 25 years. And I was like, 25 years? Are you guys out of your mind? Like, we need to do this now. And now it's like, for me, 25 years later, and
Yeah.
we're so much farther ahead, yet have so much more to do.
Yeah.
So, yeah, I just appreciate hearing about the history and things like that. But you did a great
Absolutely.
job. I
Thank
lived
you.
here, so you did an excellent job. So
Thank
thank you.
you. Well, and I'll touch on, I've shared my individual story in the sense of, with an RCO, when I came to a recovery community organization for the first time, I wasn't there to receive services. So quite literally, the impact of the RCO on me was never measured, counted, but it was profound. And so I came in as a volunteer. I was hired on in an entry level position. I had worked in restaurants previously. I'd never worked in a nonprofit. I had never worked in an office. And then over the course of time, I was mentored and supported. And eventually I became executive director. I attribute that pathway, and even the work I'm doing now, like I wouldn't be doing this work if I hadn't had that opportunity at the RCO. And so I look at this pathway and I'm like, that's pretty profound and incredible that an individual in the community was given this opportunity, was mentored, coached, professional development, all the way to an executive director and then beyond, all because of an RCO, but we're not measuring that. And so how do we start to measure those experiences? Because I know they happen in all these RCOs all the time. And so we need to expand what we think of as individual peer support services.
Yeah, that's really interesting too, because I never thought of it that way, but that was how I got involved as a volunteer about like recovery housing at the time, and then went to a rally and then continued to volunteer and, eventually got hired and then got
Yep.
promoted, you know?
So how do we measure
So,
that? Because it's a
yeah,
lost story, and yet it has a profound impact on our communities.
yeah, that's a
Yeah.
real, I'll spend some time thinking about that one. So
Good.
I'll get back to you. Okay.
Thanks, Cheryl. Michelle, you had a question or comment?
Yeah, I did have a question. So on your slide that you had talked about the concerns about peer recovery supports kind of being siloed. Um, I'm curious if you're seeing in your state like exploitation being an issue as peers are kind of brought into treatment centers or hospitals or counseling programs. They're paid a fraction of what counselors are paid, and yet they're doing the same work counselors used to do. And from my perspective, like I didn't view it the same way that you mentioned it about it being kind of like an add-on service in places, but we are seeing that in New Hampshire. That peers are being hired away from the RCOs. They're maybe paid a little bit more than what the RCOs can be paid, but definitely less than what the environment pays normally to their existing workforce. And it's almost like they're plugging holes in the shortage of the mental health field using peers. And very often I'm getting the calls for people who want to be supported, but don't want it on the books that they're being supported, because of their reputations, where they're working, which goes back to shame and stigma. And like,
Yep.
almost like what's happening is they're being co-opted, and maybe abused, I'm just thinking about how that's been on my mind because of the people that are calling me for support because they're so isolated in some of these specifically medical
Absolutely.
systems. But just kind of curious if you're seeing that too.
Yes. Yes, nationwide. We look back to like Ajama Chara's work that she created a great peer support kind of toolkit. I think it's even back, she created in like two, I don't know, the 2000s, some tens somewhere, for the city of Philadelphia, all about how much work needs to be done on prepping the organizations to be ready to provide peer support. But the trouble is we don't have any, there's no requirements for that. So essentially, any clinical system can just hire peer support, whether they know what to do and what a peer does, and they can just bring them on staff and then kind of create a position description based on what the system needs, not based on what peer supporters are meant to do. And that's where we need this advocacy. So we're like in Minnesota, we're in the middle of a process of working with our state of kind of forming some of those things of the what can we ask of and require organizations to do prior to bringing on peers, so that that organization understands the role of peer support. How can we support them in creating position descriptions that actually match what the peer does? And then how do we build up robust peer networks so that there is a place for peers to go and then report, hey, I'm being asked to do things that are really outside the scope of my work, and then have the support they need to address that within their organization. And so I think a lot of states are in a similar place.
I was going to jump in and say, just think about the language that is used to describe peers as paraprofessionals.
I know.
What?
Yeah.
They're professionals. Why do
Yeah.
we do that? I'm at the conference I'm at. There was a couple of different sessions that were like, I'm not going to use that language. They're not paraprofessionals. These are professional people and they deserve the respect of a profession.
Absolutely. Couldn't agree more, Patrick. Well, and even in William White's early work, he described peers as non-professionals. And at that time, that's what it was. But we've grown and evolved, and so we need to be, I think, thoughtful with our language because we see our own field using that language as well. Yeah, that's kind of almost self-stigma. We want
Thank
to
you.
claim the idea that we are professionals. Yeah. Lindsay.
Yeah, so a few things. I will say that and I see that a lot in the field, that we are being co-opted to do different things. It's, a lot of that I think happens in a lot of other fields as well, though. It's particularly devastating in our field just because we are considered, most of us don't have degrees, right? So we don't have that kind of, hey, I got a degree to back this up type of thing. And that leads to people not respecting us as much as they probably should. And the pay not being very good. But part of that as well is that, like, I will say that it is so incredibly important as far as RCOs go, right? Because the environment that you go into in an RCO is just completely different from, like, I've worked all over the place. So I worked for an LMHA, right? And the way they treat peers is completely different than what you'll find in an RCO, right? You'll just support you get from people who know what you're doing and who have been there is completely different. To that, part of the problem that we have is that we have supervisors, right? As we have certified peer supervisors, which is what I am. And I have been in this field for over a decade. I came up from being a peer and I'm a supervisor. I am still required to have a clinician as my supervisor for as long
Yeah.
as I'm a supervisor.
Yes.
And my clinician knows nothing about what I do. They just
Right.
have a license and I put that in the system,
Yeah.
right? So a part of it is that we are making these requirements that peer supervisors be under clinicians all the
Yeah.
time,
Right.
right? And that also leads to, if you're an organization, you're thinking, I can hire this peer supervisor, but then I'd have to hire a supervisor for them. Why not just pay the clinician to do both jobs?
Right.
Oh, I mean, it's, I think it's definitely the way the TAC is written and the way the requirements are for Medicaid,
Yep.
and that causes an issue as well. And we are seen as less than very often.
Thank you. And this is a great conversation, and we're going to continue because the second part of the session lends very much to the topic. So I want to thank you all. This has been fascinating conversation. We're going to continue. Let's move very quickly to the announcements, and then we'll go to the WIP form. So the Center for Substance Use Training and Telementoring, CSTAT, offers technical assistance. If you or your team are interested in technical assistance, what you have to do is go to our website, that's cstat.utesca.edu/contact us. There is a form there. Once you complete that form and you tell us your concerns or your requests, someone from our team here at CSTAT will get back to you in approximately 3 days. So please keep in mind that this service from CSTAT is completely free to all of you in the community. Next. And if you want to claim your CU credits, as you usually do, remember please to complete the post-session survey. That link will be sent to all of you after the session via email. Next. And we are proud to announce that we are starting our maternal health echo. That's going to be Tuesday, April the 1st. This is a beautiful collaboration between BUL Texas and PeriPan. And the goal of this series is to train all healthcare professionals on the care of pregnant and postpartum women. So we invite all of you to take part in this incredible experience. We're going to be meeting on the first Tuesday of every month. We're going to have in the audience prescribers such as MD, DOs, nurses, recovery support specialists, peer, behavioral health professionals. The goal of the series is to address the integral, multi-pronged approach to the care of pregnant and postpartum women. So all of you are invited. This is going to be a great echo. Again, beautiful collaboration. That's Tuesday, April the 1st at 12. We're sharing the registration link with you, so please consider to attend. Thank you. Next. And this is our next session of the webinar, Thriving in Substance Use Disorder Service Delivery. In the next session, and that's tomorrow at 12, tomorrow, Thursday, March 20th at 12, we're going to be exploring the most recent research on long COVID and substance use disorder. Another great presentation. Please don't miss it. Next. And of course, next month, as always, we'll meet in this space. You all know already that the Recovery Science Series meets always on the third Wednesday of every month at noon Central Time. So we'll see you next month right here. Thank you. And I think we can start sharing Michelle's case form. And again, after she presents briefly the form, we're going to keep the same conversation. So go ahead, Michelle, and thank you again for being here.
So it's my pleasure to be with you. So my name is Michelle Lennon. I'm the president and CEO of a recovery community organization that actually started out as a family resource center as a community response to what was going on in my community, which was families being affected by poverty and substance use and not finding any resources for help at all. And, you know, pretty much deciding that we needed to become the resource at the time. We started that work in about 2013, so it really lines up with what you've just heard. And today we have 4 centers, and they are located both in our state capital, and then 2, one is in a small city, one is in a rural town, and one is in a very rural area of northern New Hampshire. So they all have very different flavors when you walk into them. They are very participant driven. If you look at the form, like it talks about how we integrated recovery community organization and family resource centers. And we actually went through all of the processes to get accredited, both with our state and then also with CAPRIS originally. And now New Hampshire has like its own like credential to be a like a recovery center of quality. And I was basically asked to share in the history of how we did this. Our 10-year anniversary is coming up. We started all volunteer, and grew to, 10 years later. We have 26 employees currently, all full-time, except for 2 who are part-time. We use some contractors for some things, and we have 23 different funding sources. So while we have some state support, we have a lot of other support as well. And the audience that I was particularly thinking about feedback, when I think about researchers, we do have one program that's gone through the process of being an innovative practice to a promising practice to now it's in an evidence-based study, and actually the final expert panel looking at this program in the evaluation that was done by the Omni Institute out of Colorado actually is coming up in May. So, I think when we talk about measures and data, in the beginning, I can tell you we didn't collect any when we first started this work, and then over time collected more and more, and what an impact that has had on a number of things, including funding and including telling the story and getting, the powers that be to kind of support the work that we do, which was huge. So I was actually invited to share this with you today. And when I think of peers organizations, the policymakers, advocacy, things like that, like our journey has touched all of this through a lot of trial and error and just being invited to share things over time. That's more how I got involved in advocacy. And I think it would be helpful, to hear from others with the passion for this type of work in the field, to continue bringing this knowledge to the mainstream of life. Because I do feel like a lot of times we do these echoes, and it's the people that already care about this stuff that show up. We do things with our recovery centers. It's the people that are interested that show up. And it's like, how do we get away, from this being such a niche issue when, we are seeing overdose rates nationally still at the rate of 9/11 happening every 2 days, according to the DEA. And yet we are still pretty siloed. And one of the challenges I do see is as we are losing leaders to retirement, Bill White's no longer really out there speaking anymore. You mentioned Mr. Kelly, and Cheryl's actually making some noise about retiring, and we lost Lindy Keller at the state level. Like, some of our biggest advocates are missing now. So it's like we need to make sure we are kind of elevating all of this work equally, I guess, or concurrently, I guess, with the people that we have in the recovery centers that have those gifts and talents that we can foster, I guess. So to give you an idea of how I started, my full-time job originally was as a family support specialist. I used to do home visiting with young women who were pregnant under the age of 21 and supported by Medicaid. And my caseload was seeing a lot of women being affected at the time by heroin use. So this was before fentanyl really hit the scene. And I worked for somebody who believed in investing in our staff for the people that we were seeing. So I just got a lot of education about supporting people in recovery. And my own family was affected. So it was like a passion for me. And I think that's common. I think most of us get into this work because we are in recovery ourselves. We have a loved one. We've been experiencing or seeing the needs and seeing them unfulfilled and want to do something. And pretty much that's where my community was. I was asked actually to fill in at a church to provide messages for a short while. And because I had done some mission work in the Dominican Republic, and I had that helping vibe in my life. So was asked to fill in this relatively poor community. And what I saw through the food pantry was a lot of people that needed support to initiate recovery and couldn't find it. And this was in New Hampshire, around 2013. There was a woman who was involved with canvassing people for expanded Medicaid in our state, who talked to me about, we got to do something. And there was a lot of chatter at that time about, we got to do something. And I just remember, this leader in my life had once said, it only takes a billionth of a volt in your brain to make a decision. And so I had said to her, we need to make a decision to do something. And so fast forward, that really great boss that I worked for actually retired. And the new boss that came in was a lot more strict with clinical boundaries than the boss that I had worked for that really practiced family support practice, which is based in these 9 principles of family support and the 5 protective factors, which really ties in nicely with peer recovery support services and the core values of peer recovery support. So we were in a coffee shop one day, and I was telling her the woes of the community that I was charged with supporting, and she just put her hand over mine in a coffee shop and said if I wanted to start a family resource center in the Tilton area, she would help me. And so that was the beginning for us. I had the support of the 5 people that were left in this church to be able to use the space. And Cheryl Pacapelli, I actually met her. She was working for New Futures, which is an advocacy organization in our state. And she connected me with funding to get trained by Jim Wolfing and herself to train the Recovery Coach Academy to some of our volunteers. I worked with the Public Health Network, who offered free training for suicide prevention. We had no money, funding. So I was looking for anything that was available and free that we could use to support the families affected by substance use in our community. One of the things as a family support specialist, I was seeing families also have young children that were affected by addiction. So we wanted to do parent education, was willing to volunteer my time. My employer said no, that there wasn't the bandwidth to be able to do some of this stuff through the church. So we held these community meetings. We tried to get buy-in. We had about 30 people show up from different parts of the community. And in the end, there was about 15 of us that were ready to roll up our sleeves and were serious about it, that continued to come, after the initial interest kind of wore off. And they became the first board of directors when we decided we had to do something formal, because what we knew is that most of the people that were interested in this work were already providing some type of, kind of nonprofit service or counseling services. They were too burnt out to give of their free time to help build what we wanted to do as far as building a family resource center in recovery center. Recovery centers weren't a thing. When I look at the services we offered, we looked like a recovery center, right? We had a women's AA meeting, we had an HA meeting, we were doing cooking classes, mostly for people affected by substance use disorder. We got free support wherever we could find it. So we used UNH's cooperative extension to do the cooking classes. And I called on my social network to volunteer their time to do facilitation in their free time initially. And one of our current board members, who was one of the founders, went and got trained as a facilitator for Positive Solutions for Families, which was a 6-week program that we could deliver that was very practical and was put out by Vanderbilt, evidence-based. You can print the stuff online for free, but it was still an evidence-based program. So this is kind of how we got our start, right? But it got to the point where I could not do both jobs. So I basically talked to the church and said, can you pay me a salary for a year? And I'll leave my job and we will try to make a go of it and see if we can really build a center. So we did that. They paid me $14,950 as a salary for the year. I was a single mother. I was just lucky. I only owed 7 years on my mortgage. So I actually refinanced my house so my kids wouldn't be impacted because of my dream to get this up. And then the state, it was just the alignment was right? So by 2016, I think it was, the state was canvassing to find out who was most ready to deliver peer recovery support services. And we happened to be one of those that they interviewed and decided, because we were already providing, this parent education. We had a little play group. We got a $5,000 grant from one of our local banks to run a play group. And we had these 12-step programs that were our local network kind of got started, that we were one of the most ready organizations. So we did a lot of work doing rummage sales, spaghetti suppers, silent auctions. We raised enough money then to get our 501c3. Originally, the church kind of acted as the fiscal agent or fiscal sponsor. I can't remember the term, but one of those things. So we were able to work as a nonprofit as we were getting this up up and ready to go. Once we had the money in the bank to get the 501c3, it made things a lot easier to go and solicit donations. So we started doing that, and eventually, with the rummage sales happening every Saturday, we were getting donations in, and eventually we had enough coming in that we thought we could support a rent. So we moved what was the rummage sales in the church into what we called our thrift store, a little storefront. And then in the very back of the thrift store, we had our family support office and our peer recovery support office. And like literally the first state contracts began to roll out at that time. And we were told we were originally not eligible for those services. But, from the very, very beginning, we began diversifying our funding. So we got the first state contract in 2016, hired our first person. We started to be able to take paychecks, and we grew from there, all through community collaboration. It was huge. We got money from the school district. We got money from and I would say not just money, like those services, like Cheryl coming in with the opportunity to get trained as facilitators, training people to do this work was so incredibly important. I already got a message that I have to close. and I can say like how we got to where we are. I got to the place after our first center was opened, or our first real center, I would say, not a thrift store, but a real center. I was literally crying in my office telling Tim Rourke that they had to find a new executive director because I am not a business person and I did not have the capacity to grow this place to the next level. And he actually put me and all of the recovery center people that wanted to through a year-long cohort, basically to give us that business administration degree that we didn't have without having the letters behind our name to get where we are. Andrea, I'm just saying, we are out of time already.
No, I could hear you for a long time. This is a great story. I love it. The way you guys have grown and all the things that you had to, to do to be where you are right now. Thank you so much. I really, really like your presentation. I would love to have you again, as a matter of fact, to discuss a little bit more about this. In the interest of time, I think we're going to get one quick more intervention from Lindsay, and then Patrick is going to do a very nice short summary. Lindsay.
Yeah, so just real quick, part of the issue that we have with like a lot of things is that we don't have a specific peer code for the federal. Oh, geez, I lost it. Where they have list all the jobs, the job descriptions for everything. There isn't anything for peers. We're actually lumped in with community health workers. We did petition last year for that to change classification of the job classification system. Sorry. And so hopefully that will get changed and it'll be updated to have a peer separate like job classification code. And that will help a lot with these things. It'll also have a clear description of what peers do, hopefully. But that was a federal thing we had to try to do last year.
Okay. So Patrick, I'm going to leave it up to you to give a quick closing of the session. Thank you.
I appreciate it, Andrea, and thank you so much for Kris and for Michelle coming today. Amazing information. I agree with Andrea. We could probably spend another hour at least talking about this stuff. So quick summary, Kris Kelly brought us a great presentation on recovery community organizations, RCOs, what they are, the history, very thoughtful and well presented history and description of the key elements, the key functions, core functions of them, and particularly how this relates to this concept of community recovery capital. Love the healthy forest, healing forest analogy, and some of the initial impact and some of the stuff that we're really trying to work on as far as how do we measure these things? How do we show the impact? You and I know we're having an impact. How do we put that into some numbers and into some results that we can show, decision makers, et cetera. And then Michelle brought us her amazing story. I love hearing about these pathways, and I I really appreciate the sort of resilience and the willingness to sacrifice, right, to get things like these going. But I do think that we can do better, right? Like somebody should not have to take a $19,000 salary for a year to get these things going. I know, it was willingly done, but I know that we can do better, and just talk a lot, I think, about the community aspect and the network and how coming together we can actually affect some really, really substantive change in our communities. End of speech. Trying to keep us on time. Andrew, you're muted.
Sorry, I was muted. Thank you to all of you. Once again, please remember to complete the post-session survey, and we will see you next month. Thank you. Have a great rest of your day.